talk about strategies, post-acute strategies in this changing market. It seems that the new thing that everyone's talking about, is to do everything in the post-acute side. Right now, everyone wants to do post-acute and transitional care. Can many of these providers, the SNF providers out there, can all of them really do post-acute, transitional, high acuity care, or is that really going to be left to a minority of providers in the skilled setting?
Well, as I said earlier in our talk, you never underestimate the ingenuity, resourcefulness of local operators who know their communities and who are deeply invested in their facilities and the quality of their facilities and the relationships with physicians in their local hospitals. Never underestimate that, because if you have the best assets and the highest quality and the best reputation, that's a have to have. But there's no doubt it will be more difficult as networks form if you're not able to plug into those networks, if you're not willing to take risk. And then there's also the obsolescence problem with the assets. We're going to continue to see length of stay decline. We're going to continue to see Medicare Advantage and managed Medicaid manage institutional days more aggressively. And so part of how the only way you're going to be successful there is if you haven't overpaid for the asset too. So we're going to have to really think about what the model, the economics of the model look like. And fundamentally for skilled nursing, the problem is we're just losing so much money on our Medicaid custodial days. So, and that's why you're seeing so many people want to build, Medicare only, and really only Medicare fee-for-service only. Because that's where the return on invested capital is.
How about geographic concentration and geographic strategy? Let's say you're a post-acute provider, you have the skilled nursing, you have LTAC, you have rehab, home health. How, if you want to really have that integrated care market and a core market, how big geographically can that market be, or should it be? To be cohesive, where you're working together.
Well, but all the markets are so different.
New York City is different from Nebraska.
Houston's 7 markets, right? And we have a big presence there, but it is a huge market with different characteristics. Chicago is a very different market. I think one of the exciting things about Gentiva, Kindred at Home today, is it actually allows us in a much more fungible way to spread our market capabilities. So our hospitals, our IRFs and LTACs may still be our hub, but home health, hospice, our skilled nursing, our rehab care customer base allows us to touch the different neighborhoods in a different way.
Well, let's talk about Kindred, Gentiva, which is now Kindred at Home. You got your 23 integrated care markets, and that the home health gets really spread out there. Does that matter for efficiency?
Well, we're deeper and broader.
Yeah, you're
both.
Okay, the deep I understand. The deep to me works. That broad.
Well, broad. If you look, the decision, the strategic decision for acquiring Gentiva was pretty simple. If you look at the projected growth of post-acute utilization over the next decade, government statistics, and you're great with that, but home health has got the highest organic growth rates. It is where consumers want to be. It is likely where a lot of the population health is directed through telemedicine and other things. So if you want to take risk, if you want to be part of a network, if you want to save beneficiary dollars on a per member per month basis, then you want to have physicians, integrated IT, home health, hospice, and palliative care. And so it is on a distinct basis a superior investment, and it's proving itself to be that. And then on an absolute basis, in terms of building out our capabilities to participate in these new models, it's just strengthened the Kindred portfolio. It's made our it's made our hospitals, LTACs, IRFs, and skilled nursing facilities more strategically positioned too. I mean, we're discharging 50–60% of our inpatient, and higher in the IRFs than anywhere. 50–60% of our inpatient patients are being discharged to home health, and many of them are choosing, because there's patient choice involved here, to continue the care. This is where continue the care comes with home care, because the rehab care therapist, our nurses, our clinical programs, so we're extending the care, the recovery into the home. That's what patients want.
Outside of your 23 core markets, are you partnering with other providers?
Absolutely. So the Centere acquisition, and if you look at it, look at our Kindred Rehab Hospital Services. We have 100 hospital IRFs that we operate. So many of those are not our integrated care markets. So I think you have to look at our platform a little differently now. Yes, we're very focused on the integrated care markets, but in many markets, we now operate acute rehab units where we have Gentiva, Kindred at Home resources as well. And so we are, in a less asset-intensive way, starting to continue the care on the road. We're trying to do that with our ALF partners as well, doing rehab department and home care. In many cases, we're offering those services joint to assisted living facilities. So what we're trying to do, and what Ben's done a tremendous job of, is trying to figure out, all right, how do we expand our footprint in a more virtual way so that we are and can help our patients and our partners participate in more integrated post-acute care beyond our integrated care markets.
How about ACOs? Have you joined a few?
We actually own one.
Bought one.
We acquired a controlling interest in Silver State, but it's a partnership. Our physician partners there are integral to the success of that. And we're very excited about the learnings there. We're participating in a few bundled payment demos as well. I would say those are a little bit more challenging, because I think bundled payments are intellectually very appealing, but they're very complicated to execute on, and I think that's what CMS is finding.
So you're kind of going up the learning curve on that now?
Yeah. So, we continue to believe that there's a journey here moving away from fee-for-service, and that journey will include, more value-based payment, pay-for-performance type things. Some R&D about taking risk on a per member per month basis, maybe in partnership with an ACO in some markets, or doing our own ACO, or doing our own chronic care ACO, consistent with Senator Wyden's idea of how do we, maybe create an ACO for chronic care patients, and we would love to work with him on that. So I think there'll be, these are R&D that are going to take a while to mature.
Because some of the original ACOs, you've been reading the press, they've kind of disbanded. It didn't work. They had problems. Do you think ACOs will be the future, or is this an intermediate step and something else will evolve?
Well, as we move from 5 big payers to 3 big payers, and then the government, I think we will see hospital systems during that intervening period figure out how to gain market share, and I don't mean just in the conventional way, but through their physician strategies, through their ACO strategies. So like most things in life, usually the first iteration, the first movers don't work. But usually these things tend to get some traction the second or the third time around. I mean, part of the reason the ACOs aren't working right now is you can't select, right? I mean, you have to take all comers, and you can't manage the patients, and you can't have unlimited choice and then actually hope to have a good outcome in terms of cost and quality and access.
Right. And then you go back in the skilled industry with capitated payments, and I think it was integrated in Mariner, not when you were with Mariner?
Oh, no, I shut down the capitated arrangement.
And so that was the big thing.
It's a disaster.
And now we're 20 years later.
And we're deja vu all over again.
Yeah.
So we had,
but have we learned?
We were losing $1 million a month at Mariner in the 20,000 lives that we had capitated in Florida. So when I became Chief Operating Officer at Mariner, Dr. Stratton, great guy, good strategist, was ahead of his time. I said, Art, this isn't sustainable. The best thing we can do for shareholders right now is shut this thing down.
Yeah.
So we did.
Yeah, but is that, I mean, did we learn anything from that?
We totally learned. Because now we have risk corridors, now we have the Medicare Part D prescription drug piece. I mean, the world has evolved a lot. That's what I'm saying is the first iterations typically don't work. But by the way, remember, we had a world then that 80% of the physicians were in sort of private groups. Today, 55, 60% of the physicians are employed. We're going to see, so physicians are still the drivers of healthcare in America. Nothing happens without a physician making an order, and rightly so. So I think that, integrated care, population health is very dependent on building team-based healthcare models with physicians directing care, but also acknowledging that given the population challenges we have in the expansion of Medicaid under ACA, we already have a deficit of primary care docs. We're going to have to figure out how to get everybody to operate at the top of their license. So.